Please be seated. May I request the service officers to close the doors on the left-hand side, please. The session has started. The Secretary will read the order.
Debate on Vote 16, Health Appropriation Bill 2019.
I now recognize the Honourable the Minister of Health to introduce his budget vote. The Honourable Minister.
Thank you, House Chairperson. The Honorable, the Chair of the Portfolio Committee on Health and members of Parliament, my colleague, the Deputy Minister and other Deputy Ministers, Ministers and Cabinet members present, my colleagues, the MECs of Health from the various provinces, heads of public entities, statutory councils, professional bodies, unions, civil society, the deans of faculties of medical sciences and other academic institutions, including medical research councils and other councils, members of the public, ladies and gentlemen, and fellow South Africans. It is indeed a pleasure for us to table today the National Department of Health budget for 2019-2020 at 51.46 billion rand. The President in the State of the Nation address in the 6th Parliament indicated that we have to attend to the capacity of our hospitals and clinics. To this end, we have a social compact which has emanated from the discussions in the Presidential Health Summit in October 2018. It will be signed by the President to confirm the partnership between government, the private sector, academia, health professionals, civil societies, including the organized labor, to build a health system for the country that will be ready to implement the universal health coverage. And therefore I welcome in the presence today of all the stakeholders who are partners in health, who are amongst us here, as I've indicated, from the private sector, from the members of the public, patient associations, advocacy groups, the academic and research community, the various other sectors, such as the representatives of various professional bodies and regulatory bodies who are here. I really do appreciate your support throughout all this process. We recently attended the G20 summit, in which health and finance ministers reconfirmed the commitment on our shared understanding about the need to strengthen health systems and health financing with the aim to achieve universal health coverage. And a point we made is that investment in health, expenditure on health must be seen as investment in economic growth. The head of the Director General of WHO, Tedros Ghebreyesus, put it nicely, and I quote, he said about the potential payoff for the universal health coverage, that it's children who survive beyond their 5th birthday because they're immunized. It's women who are able to start small business because they don't spend all their capital on healthcare. It's men who don't die before their time from non-communicable diseases, unquote. So it's from this backdrop that we have to express our confidence to commit to this cause despite all the existing challenges of staff shortage of medicine, aging infrastructure, inequity in the access, and inadequate equipment, amongst the others. We have to use the critical levers of health to narrow the gaps and bring about the resolution of the country's woes, such as low economic growth, inequality, poverty, unemployment, and prevent the recurrence of human rights violations such as life demeaning. It is on this basis that on which people through their president have sent a very strong message demanding improved services and elimination of long queues in health facilities. And what we have to do in health is in line with our goals on the National Development Plan and on Sustainable Development Goals. The major challenge on the health system is the increasing burden of disease and the twin epidemics of communicable and uncommunicable diseases. So based on the outcomes of the Presidential Health Summit, we have put together some steps to intervene and deal with the health system. These interventions help to transform the system, correct its weaknesses, but also create a platform on which to implement the NHI, which is a way of providing social solidarity, providing good health care for all by sharing money available for health care amongst all our people. The health benefits that you receive will depend on how sick you are, not how wealthy you are. Under the NHI, health facilities and health workers will also be available to provide health services to all more equitably. It all depends on our willingness to share as one nation, and if we can feel and act in unity about sports, surely we can do the same when it comes to issues of matters of life and death. So the National Health Insurance is a chance, therefore, for South Africans to hold their hands together and really work together regardless of race, gender, or creed. Now, we have said that there have been concerns about the readiness of our system to implement NHI. I believe that too much of discussions have happened, analysis, diagnosis have been done. I think it's time for us to just jump into implementation. So if we continue analyzing the process, the whole problem, you'll end up never actually getting to battle. And for that reason, we believe, therefore, that there are a number of issues that we must tackle immediately. And when we do so, we're doing both the resolving the problems in the health system, at the same time creating a platform for the implementation of the NHI. The first is the issue of equitable funding for the public sector. I think as we have been discussing across with my colleagues, all provinces have got a feeling that health is significantly underfunded, and therefore the current baseline needs to be corrected, particularly if you look at the size of the health service, the burden of disease, and the quality that's expected out of it. To this end, we are engaging National Treasury to explore various modalities to adequately fund the health services, but in the long term, investment in the NHI will create funding mechanisms that will permanently resolve this problem. Shortage of staff is the second problem. We believe that the shortage of staff in the frontline service delivery needs to be eliminated once and for all. We've identified the shortage of staff. We've identified the shortage of staff that require attention. So of the 4,143 medical officer positions, we are ready to fill 2,680 of those this year. And then, of course, a proportion of the nurses, allied professions, and community health workers that have to be also given attention. We give the figures in the detail of the text of the numbers that we think can be accommodated. But to be able to do this, we've actually instructed our departments to go and look for possible sources of funding to divert to this particular priority. And therefore, the Department of Health and Treasury now have got a team that's working on reprioritizing the budget, looking at vacant posts, looking at structures that are bloated, that need to be downsized, looking at projects that need to be abandoned, and also looking at restructuring conditional grants. All of this we'll report as we move on, but effectively, we're looking for alternative additional sources of funding. And mind you, I've said that even the original baseline does need to be looked at. That of the issues is the supply of medicine. I also believe here that we need to give this attention. Budget for medicine needs to be ring-fenced and protected to prevent drug stockouts. So we are looking at an app, a mobile app, which will allow immediate reporting by patients and civil society every time that vital medication is not available in clinics and hospitals, so that there's a quicker feedback to the management to correct the situation, both at provincial and at national level. We have also identified situations where there are global shortages. We will always endeavor to ensure timeless alternatives that must be supplied so that people don't go without any medication. The South African Health Products Regulatory Authority will also be strengthened to ensure that they speed up the registration of medicines and also build up capacity for local production of active ingredients, as well as removal of application backlogs, and accelerate the applications to make it easy for drugs to be accessed. We're also exploring procurement of available software to ensure that we can actually dispense medication closer to where the patients are. And we're partnering with NGOs that have already done work on this particular area, focusing on the areas of townships, informal settlements, and rural areas. There are areas already where we are able to get medication delivered without patients having to go to hospitals. This again will assist to reduce the patient waiting time and people just walking to the hospital just for medication. The impact of these steps that I've indicated will be that of reduction of patient waiting time, less overcrowding on hospitals, and managing patient workload for both staff in the clinics and hospitals, and ensure that our people have medication without the inconvenience of unwieldy queues in the hospitals. The other issue to focus on is that of quality improvement. Here we welcome the reports by the global and local and national Lancet commissions on the quality of care. The quality of care in the government-run facilities must improve to make the public sector a service of choice in terms of access, affordability, availability, appropriateness, technical competence, skills, effectiveness, respect, and caring, amongst others. So when people approach our public sector, they will be doing so because it's their service of choice, not because they've got no other way to go. We will therefore be using the Office of Health Standards Compliance to monitor the improvement of quality at different levels. We'll also be working on client satisfaction surveys to track some of the very sensitive issues which we believe that management needs to be alerted quickly enough to be able to ensure corrections, such as quality of food, linen, hospital linen, cleanliness, attitude of staff, etc. All of these for us are non-negotiable, for which we need to make sure that we partner with advocacy groups, with civil society, with our patients or our clients in ensuring that they give us feedback to help to correct the system. Then, of course, we want to strengthen the Office of the Ombudsperson, which is a channel where communities can raise concerns about the quality of health services. This one we will strengthen, and also we're going to work on a combined strategy of improved clinical care, efficient administration, backed by strong legal interventions to reduce medical legal claims by more than 50%. The fifth is improvement of governance. Here is we intend to strengthen leadership at various levels to bolster service delivery and place the patient at the center of care. We'll review organograms and also look at bloated, inappropriate structures, and review, adjust delegations, and ensure that there's authority at the correct levels for effective decision-making processes. And that way also fight corruption and promote ethical leadership and eliminate wastage. Consultation with the heads of specialist disciplines will be undertaken to strengthen clinical guidelines at tertiary and regional hospitals to ensure that we build capacity for all the managers and strengthen the system. To improve governance also at our health facilities, we'll ensure that clinic committees and hospital boards are up and running by the end of this year. These structures will be trained so that whenever these feedback mechanisms begin to kick in, they are able to effectively assist management of a clinic or a hospital to make amends and correct the system so that the patient service is improved. Sixth is infrastructure build. Here, we believe that for the public to believe in NHI, the quality of the infrastructure has to be improved. Currently, there's 19 billion which has been set aside in the MTF to refurbish a number of hospitals and build new hospitals at the same time and clinics. But this is a lot of work that's been done, but we also believe it's not enough. The department at the moment has actually done a whole cost analysis and audit of the quality of the services and the cost it would take to revamp literally every hospital or facility in the country. So I've set up a team of experts in finance, health, and health infrastructure from Treasury and Health to seek creative financing mechanisms and alternative models of delivering health infrastructure. We've given them a clear directive to look at a program that can actually start delivering literally refurbishment of all the hospitals and building new ones within a horizon of 5 to 7 years. Now, this is a basis on which the NHI will be operating. Our current preliminary indications are that such is feasible, and therefore we're going to work on a plan that once it's developed, we will then be approaching provinces and all other stakeholders to ensure that we can start that massive infrastructure build. 7 is strengthening primary health care and reorganizing the district health system. Here, we believe that strengthening various cadres, community caregivers, community health workers, clinics in the hospitals, nursing care, as well as district hospitals, working together, particularly with outreach program from doctors to go and ensure that patients can be seen without having to go to hospitals, and in the process also bring in the services of general practitioners in private to be part of this whole base on which the NHI is going to be built. And here, this move has also got support from South African Medical Association, Unity Forum for Family Practitioners, Progressive Health Forum, and so on. So we have lots of guidance on this area to try and take that process forward. It's important also to understand that there's a role for traditional practitioners and other allied complementary health professions in the building of this primary health care, and we are going on with the discussions on how those roles must be further defined. We've also got support from the health professions councils, the pharmacy, nursing council, traditional health practitioners councils, all of whom are also looking at what role they can play in strengthening that whole system. On stakeholder management, we believe that we have to deal on this matter as a partnership. Literally, all of us here have got an interest in the building of the health services, and therefore we will be looking at strong angles of dialogue to be able to deal with various aspects that will strengthen the health system. And we are therefore going to be setting up an office for the implementation of the National Health Insurance that's going to give us a preliminary plan of how this unit is going to operate. This is about focusing on building on the NHI fund, building on the capacity that is needed to manage the national health insurance, looking at the various models from various countries in terms of accounting, purchase of service, actuarial calculations. All of those issues are going to be worked on by this team, and in the process, we also have decided that a number of people must be trained in this regard. To start off with, there is also the patient registration system, which has at this moment registered 42 million South Africans, and by the end of the year, we intend to ensure that all South Africans are already registered for NHI on a single registration. We'll also be working with the Department of Home Affairs for birth registration so that children are loaded onto the system, all of this on the time frames of the Department of Home Affairs. We have worked with the deans of and heads of specialist disciplines to look at how to strengthen the capacity at the hospitals as well as in the administration. So we are identifying 30 managers within the next 4 weeks who must go out and be placed in institutions across the world who are practicing the national health system or national health insurance system so that they can actually learn on the spot. And here we use the agreements that have come from JICA in Japan, UK, DFID, French government. Then in addition, the academic institutions will identify academics who will also be part of this program. And then we use twinning to be able to build capacity in South Africa so that ongoing capacity on management of NHI will be resident inside the country. Amongst the programs that we'll be identifying for purposes of initial loading on the identified district using the report on the pilots as well as the report of the Health Office of Standards and Compliance will then be identified about 20 districts from which the first load of various programs is going to be focused on. HIV and AIDS is one of those, and we spoke about the 90-90-90 goals and the need to raise 2 million other patients for treatment, as well as elimination of defaulters with tuberculosis. That will be focused on the campaigns that we're going to deal with for focusing on vulnerable groups, particularly the younger women and men for testing. All of these we're going to be focusing on. We note the progress that has been made in improvement of the life expectancy because of the antiretroviral treatment, but we are concerned that the numbers are still rising, and so we have to reduce the incidence of TB, incidence of HIV as well. All of these are issues that we're going to be loading for earlier focus as we start the program of NHI. And so the other area is going to be access to rehabilitation for psychological and mental health services for all our people to deal with the issues, particularly those who've got HIV and TB, but also on issues of unnatural causes, the issues of domestic violence, other crimes, and so on. We're going to have to work together on all of these. The other area that's going to have to be strengthened is that of the National Health Laboratory Services, which is doing brilliant work now in supporting all the hospitals, and therefore their turnaround times have improved and their cost effectiveness has improved. And this is going to be fundamental in dealing with supporting the NHI. So amongst the services that we will be focusing on immediately for those districts where we'll be strengthening NHI immediately is maternal and child health, neonatal health services, sexual, reproductive, and adolescent health, issues of support and rehabilitation for the disabled people, services for the older people, palliative care, and particularly those patients with cancer and HIV at terminal stages. Will then be tackling both communicable and non-communicable
Honourable
diseases.
Minister, your time is now expired.
Thank you very much.
Thank you. Before I call the next speaker to the podium, I would like to welcome our guests in the public gallery, but I will request you that you switch off your cell phones, please. I didn't want to disrupt the minister when he was busy with his speech, but there's a number of cell phones that went off. Please switch it off so that we don't have any further disturbances. The next speaker is the Honourable Dlomo.
Honorable House Chair, Honorable Minister, Dr. Zulim Kize, our Deputy Minister, Dr. Joe Pashla, members of Portfolio Committee of Health, honorable members of Parliament who are present here, our guests, ladies and gentlemen. Let me take this opportunity to congratulate both our Minister and Deputy Minister for being appointed by our President to lead health in the country, South Africa. Your past excellent contribution in health leadership in our country and in Africa and internationally will be a treasure for our country. We would like to offer our support and good working relationship as we all discharge our different responsibilities towards improving health conditions of our citizens. In 1978, leaders of the world, health activists, social activists, and all peace-loving and health-promoting activists met in Kazakhstan to deliberate on issues of human development and health. The meeting closed with a declaration which is known as Alma-Ata. This declaration had a theme, Health for All by year 2000. Health for all citizens of the world. Some citizens came back thinking that this 22 years of waiting was a long period to wait for a dream that would bring dignity, at least to our poor people. Needless to say that year 2000 came and it has now gone, and there was no health for all in the world. 19 years have since been lived, and there's still no health for all citizens in the world. This dream has been delayed by those who continue to benefit from the inequalities of health in societies. This dream for us in South Africa is anchored on the Freedom Charter of 1955, Clause 9, which talks about a preventative health scheme shall be run by the state. Free medical care and hospitalization shall be provided for all, with special care for mothers and young children. The former Director General of WHO, Dr. Margaret Chan, has mobilized leaders of the world to universal health coverage. So it is time now that we move to a progressive realization of this dream of the Freedom Charter, the dream of the Alma Ata activists. We cannot wait any longer. We have termed our universal health coverage, NHI, in our shores. We are saying, can we be able to attempt to provide health for all? What financing system are we going to put in place to provide such a noble program? A program that emphasizes on social solidarity, that talks about NHI being a public good, that says we must carry along those who are less fortunate and less resourced to be able to provide health for themselves, majority of whom are blacks in general and Africans in particular. Opposing NHI is like a statement of a conversation that I could refer to and someone conversing with someone in this way. Dear my domestic worker, I'm grateful to you for looking after my house, my children, while I'm in Parliament. Thank you for helping my children to know how to cross the road from school. While I have a medical aid called PAMED, I don't think that you deserve it. Over and above, I'm not able to support any program that seeks to give you good health.
Honorable Deputy Minister, we have a speaker at the podium. Let us keep the interjections down, please.
I'm not sure why there's an objection, because I'm relating to a story that could be said by any person who has a domestic worker at house. I'm not referring to anybody in the house. If there is anybody in the house, then it's fine. And the conversation will go on to say, we do have a pool of so many domestic workers around us who, if your health deteriorates, I'll go and pick one more and I don't have space and time to take care of you. Because good health is for those who are rich. This is quite an immoral and uncaring attitude of some of the citizens of the world, and probably some of them are in South Africa, and probably there are some of them in the house. They continue to say, just fix your clinics and hospitals, and everything will be okay. Our research shows that there is no country in the world that waited for all things to be fixed, clinics and hospitals, before implementing universal health coverage. We say we will fly NHI as we fixed our health system. Returning to the other program, just last week we received 200 Cuban-trained fifth-year medical students returning to our motherland. This week and next week we'll be receiving many more, bringing a total to 647 returning students. We commend the Department of Health for this vision of sending students to Cuba when our universities at that time were either unwilling or unable to increase their enrollment. The benefit of these returning students, who come from all over South Africa, of course, except for Western Cape, for reasons best known to the DA, is that they bring with them a depth of knowledge in public health, trained in the country that has achieved the following. Cuba has improved the life expectancy above 70%, 70 years. Cuba has eliminated malaria. Cuba has little or no maternal death. Cuba has little or no infant mortality. Cuba has little or no under 5 mortality. If we want to strengthen primary health care and, of course, NHI in our country, we must tap on this model of training students in Cuba. But I'll probably advise Honorable Minister to maybe look into a situation of maybe bringing such a model, this Cuban training model, in our universities in the country. I received a letter on the 9th of July from a Mr. Mpho Mpocheng, a president of the South African Emergency Practitioners Union. I phoned Mr. Mpocheng the same day to acknowledge his letter. We further agreed that our offices will set up meetings addressing the issues raised in the letter, namely the plight of emergency medical officers in our country. This meeting is since scheduled for the 23rd of July, where we are going to tackle this matter. It will be important to know, Honorable Minister, how you plan to assist our workers who are in this category. Honorable Minister and our Deputy Minister, I think it is staggering for people to come to our clinics and hospitals, finding nurses assisting injured people and threatening nurses to stop saving lives. Those incidences have happened in various parts of our country, recently in Gauteng and KZN. We need to collectively condemn these atrocious acts. Again, Minister, we need to work with you on the plight, on these social ills. After all, safety and security of our staff members and patients is one of the pronouncements of the department as the non-negotiables. We have since learned that on infrastructure, Honorable Minister, you are having plans. This government has actually done quite a lot, but we need to look back that not only were you building new clinics, but you also had to revitalize a lot of clinics and hospitals who were built previously by the apartheid government in our homelands. But there were no maintenance plans that were put in place to really make sure that those systems are in place. That is why, among other things, I just referred to the province where I come from, that King Edward Hospital has actually been revitalized by money over 200 million following storm damages that came to that province and other parts of the country in various hospitals. Honorable Minister, you need to review your plan on infrastructure, as we would like to support you on any efforts that you'll put in this regard. There's more pressure to build new facilities, but also you have to look backwards and improve those that you have already built. Minister, on my previous life as a soldier, I actually am really concerned, Minister, when I noticed this in health, that when a member of the SANDF, a soldier, were to report to a Palabora sick bay, he or she will produce a false number and the medical file is brought out. That visit is also recorded electronically for not only for the member, but also for the dependents of that member. when the same soldier comes into 1 million Pretoria and 2 million Cape Town, and actually the file is retrieved within seconds. So there are no waiting times for files in the sick bays of the SNDF. There's no file lost in the army in our country. And there are no unscrupulous lawyers that visit and take our government to court because the medical records were lost and they are not found. In that situation, therefore, Honorable Minister, we now know that there are no litigations that come to the army unplanned and unable to deal with because we don't get files lost. You don't have patients waiting 2 hours to get a file. Honorable Minister, we really plead that this must really be looked into as a matter of urgency. On the staff subject, we note what we have said and we actually support that. But we would wish that, Honorable Minister, you consider, among other things, other categories of staff to be employed beyond those that you mentioned: porters, clerks, cleaners. A clean hospital would not need a professional nurse. Taking those who have left this world into the new world, into mortuaries, is not done by nurses. And therefore, in shortages, so if you leave and ignore these other categories, you might just find not a hospital working very well. We note your comments on the medical stock out, but we note, we would like to say the explanation given by the department that the medical shortages is a global problem that affect all countries due to supplies of active pharmaceutical ingredient. We would want the department to be proactive, among other things, announce and have a plan of how institutions who are experiencing drug shortages would actually convey that message to the public. It is not acceptable that if the medicine is not available and therefore cannot be given, maybe for good reasons, there is no proper communication to the citizens of this country as to when and how I will get the next medication where. Honorable Minister, would like to get a detailed plan of your department's fight against non-communicable diseases. Your annual performance plan does touch on this matter, and it talks about exercise in fighting diabetes and hypertension. Countries, Honorable Minister, that have had a good healthy lifestyle have actually impacted very positively on non-communicable diseases, because things like those delay the onset of diabetes, they delay the onset of
Honourable
hypertension.
Member, your time is now expired.
We support the budget of the minister.
Thank you, Honourable Member. The next speaker is the Honourable Garube.
House Chairperson, South Africa is one of the countries that spends the most amount on health care, with an accumulative budget of over 222 billion rand across all departments and its entities. One would think a department with a budget this large will be delivering, at the very least, an adequate level of care. But all of us in this House know this not to be true. This is confirmed by the poor health outcomes of the majority of the provinces and the lived experiences of the people that we are meant to serve. 25 years later, kusekho abantu abajikiswayo kwiikliniki zethu apho bamele ufumana uncedo khona. Kusekho oomama abaphela bebelekela ezibhedlele kukhanyiswa ngeethotshi ze-cellphone kuba kungekho mbane. There are still hundreds who died in unlicensed NGOs during the ACDP tragedy, and thousands who were sentenced to death by a completely preventable oncology crisis, as was the case in KwaZulu-Natal under Dr. Sibongiseni Dlomo. This is the direct result of poor policy and no consequence management for provincial departments that underspend and embezzle public money, and the sheer lack of excellence-driven leadership at the political level. Yesterday, the Cabinet announced that the NHI bill will be approved and will be later presented to Parliament. It is unclear whether a costing has been finally done and whether in its finalization, the lessons learned from the failed pilot project have actually been taken on board. This bill came at an initial price tag of 259 billion rand, and then the previous minister then admitted that this was in fact a thumbsuck. The legislation will see nationalization of healthcare, the creation of a state-owned enterprise, which will be the perfect breeding ground for mass corruption and slow delivery of care. NHI pilot projects across the country have failed in a spectacular fashion. As such, the minister and his predecessor have sat on a report that will give a fair assessment on these projects. When I asked the minister last week about this report, he simply said he does not care what it says. He said it does not matter how much the bill will cost to implement. This government will simply push ahead.
Order, honorable members. Order. Don't drown the speaker with your interjections.
Minister, this is quite frankly a dereliction of your constitutional obligation and your responsibility to the people of this country. More concerningly, we are aware that there are provinces that are yet to be fully engaged with what will be expected of them with the rollout of NHI. There has never been a constructive discussion about this legislation at the National Health Council with the 9 provincial MECs and their heads of department. To add insult to injury, over the medium-term budget, there has been a 9 billion rand reduction in the investment of primary health care, which is the real interface with our communities. Any legislation that will see the improvement of a health system needs to do so from the bottom up, and it needs to start at the primary health care level. It cannot start in the corridors of Luthuli House. The minister, what is clear to me is that you are here to fight for the ANC and an ideological win. On the other hand, the DA is here fighting for the people of this country. Nationalization of healthcare will not bring about the dignity to the millions who depend on public healthcare. The road to universal healthcare does not have to be paved with fundamentally bad policy proposals. South Africa can have universal healthcare that will see the entire system transformed so that it can serve the people who've been left behind for 25 years. Under a DA health plan, people would need not to wait for 15 years for their lives to improve. They would not need to wait for billions of rands that we do not have in order for them to have access to good health.
Chair.
The DA would roll out universal health care in 5 to 8 years.
Honorable member at the podium.
It would.
Let me just take this point of order. Why are you rising, honorable member?
The honorable member on the podium, it's a maiden speech, and can you please protect him?
Well, the whips of the DA should have informed me it's a maiden speech. You didn't inform me. Honorable members, a maiden speech is usually given the opportunity to be heard. However, if you become controversial and you raise issues where you are attacking other parties, then you must expect to be heckled as well. And I will order. And I will intervene where necessary. Continue, honorable member.
The DA would roll out universal health care in 5 to 8 years. It will be delivered through restructuring and reprioritization of the current health budget. It can be financed in 2 interventions. We would remove the medical aid tax benefit afforded to medical aid clients, availing immediately 17 billion rand. That would improve primary health care, which is the bedrock of the system. It would be invested in maternal and child health. It would improve the provision of emergency medical services. With those interventions alone, the health system would drastically improve. It would not end there. We would assign
Honourable
every single
Chair.
South African with a subsidy that would afford them a
Honourable
standard
Chair.
health package.
Can the member take a question? But they did not indicate, Chair.
Session, honorable members. It's a maiden speech. Let's allow the honorable member to continue. During order. Switch off your mic, honorable member. During a maiden speech, you don't ask questions to a member who is delivering a maiden speech. I'm told the member has spoken in the House before, in another debate. Honorable member, are you prepared to take a question? She's not
Chairperson, I've
prepared
got
to
a
take
lot
a
get
question.
through. It would not matter if you are in private health care or in public
Order, honorable
healthcare,
members.
you would still be fully covered under a DA health system. This means under a DA system, our people will not be relegated to a second-class health system. They'll be able to access whatever health facility they want. Instantly, the system of insiders and outsiders would be done away with. In order to bridge the gap between those who have medical aid and those who do not, the DA would impose a health justice fund. This would be cross-subsidization funding model to provide a standard package of healthcare that is of quality. In this way, we would give agency to our people. We would regulate the private health schemes so that people are not exploited. And we would ultimately roll out universal health care that will not destroy the economy, but that will also be affordable. Our fight is for the excluded and the victims of a system that has cost millions their lives. It is not against the ANC. It is not against you, Honorable Minister. We are bringing solutions to the table to afford people dignity. We hope that the ANC government would finally place the patient at the center of reforms and legislations coming to this parliament. If it does not, we will fight this bill on behalf of those people at home who've been left behind for decades under the ANC leadership.
Order, honorable members. The next speaker is the Honorable Temba Kwayo. Order, honorable members. Order.
Chairperson, thank you very much for this opportunity. The economic freedom fighters declared 2018 the year of public health. We committed ourselves to visiting all public health institutions across the country to find out for ourselves the conditions under which the public health services are provided. Minister, we found a public health system in distress, suffering from many years of neglect, incompetence, and general lack of strategic leadership from the highest office on the land responsible for health care. Just in the Eastern Cape alone, there were 110 health facilities, clinics, and hospitals which were without electricity. Around the country, over 600 health facilities had asbestos ceilings, 570 had asbestos roofs, and over 116 had asbestos internal walls, exposing poor, sick South Africans and medical practitioners to long-term damaging health risks. When we asked, our department told us that the department was short of over 18,000 nurses, 2,250 doctors, and 154 dentists. This is over and above the total collapse of oncology services in KwaZulu-Natal and general shortage of other specialists across the country. In addition to this, we have poorly trained hospital CEOs, overworked and underpaid doctors and nurses, hospitals without necessary medication and machinery. The general state of public health in this country is in crisis, in a pervasive state of disrepair, and is exposing poor South Africans to health risks that could otherwise be prevented. While the majority of the poor, predominantly Black and African, and largely dependent on the disintegrating public health system, a tiny minority of about 16% of the population is well taken care of in the public health care. These people with medical aids can access the best quality health care because they have the money to buy health provisions. 44% of all health care spending is concentrated in the private sector, which serves only 16% of the population. The remaining 84%, those with the largest share of the burden of disease who need the most care, rely almost entirely on the under-resourced and dysfunctional public sector. As a result of this, there's a huge public inequality, massive unmet health care need in South Africa, and a failure to approach anything near universal health coverage through accessible, equitable, and effective health care services. This cannot be allowed to continue, and the country as a whole must go back to the drawing board for a social compact to eliminate these discrepancies. As a matter of urgency, we need to do the following: outlaw the dual nature of health provision in the country, where the rich can go to private care while the poor are subjected to poor conditions in public health system. We must develop one quality healthcare system that provides the best possible healthcare to all our people. This must be done through legislating for universal health coverage under the overarching National Health Insurance Framework that will ensure each and every South African, regardless of the state of wealth, has access to the best medical care in the country. The rollout of the NHI will be meaningless and will only amount to posturing if it is not preceded by a massive investment in public health infrastructural development, in employment and retaining of medical practitioners, in procuring medicine and machines for all public health facilities. There must be a clinic in every ward in South Africa, and all clinics must open 24 hours a day, with nurses and a doctor in each clinic. Our focus on clinics is informed by the belief that the country must focus on primary health with a commitment to attain universal health coverage, with the intention of decreasing infant mortality rates and increasing the life expectancy of all people of South Africa. We must regularize and fully integrate community health care workers as full employees of the state, who will be responsible for provision of quality health care in each and every community. We must, as a matter of urgency, build 24-hour integrated post-sexual trauma centers in all district hospitals for urgent medical, forensic, psychological, and social assistance directly linked to policing and detective directorates. The majority of South Africans believe in traditional healing methods. This must be integrated to the manner public health services are provided. Consequently, each hospital must be equipped with consulting rooms for traditional and indigenous health practitioners, traditional healers, and traditional herbalists to use for free in all district hospitals. Establishing at least one healthcare training facility per province, ensuring that there is no province without a medical school. In addition to these issues, Minister, you need to commit yourself that all these clinics and hospitals without electricity will be fully electrified within a year. You must commit that your department identified young South Africans from grade 10 who will be supported to study medicine and nursing after completing grade 12. These students must be supported in every possible way. Despite the 18,000 shortage of nurses around the country, in Lusikisiki in the Eastern Cape, there is a group of over 300 qualified nurses whose studies were funded by the department, but who have been unemployed for the past 3 years. We must all agree that the past decade under Minister Motsoaledi was a complete waste
Honourable
of
Member, your time is
for
now
health
expired.
provision, and we must correct that. As a result, EFF reject this budget.
Order, honorable members, order. The next speaker is the Honorable Schlangwa. Order, honorable members.
Speaker, Honorable Minister, and House at large. Speaker, our public health system in South Africa is in crisis. There is a little to no indication of this sector facing the reform needed. People do not trust our health sector in South Africa, but have no alternative other than to use it. Minister, KZN sitasibonga ukuthi ukhona uphila mntwana lapha emaklinikhi ukuze kuyofika ema-crash. Siphinde sibonga ukuthi uminister uzibophezela ukusebenza namakhosi kanye nawo bonke ngoba siyabona nezinga le-circumcisions liyenzeka. Siphinde sibonge siqinise futhi uminister akawaqinisa amaxhama phakathi kwama-traditional healers nama-clergy ngoba ama-traditional healers azokusebenza ngemithi udokotela uzobe sebenza ngosizo bese kuba khona ama-clergy to heal the spiritual part. The Health Professional Council of South Africa, HPCSA, for instance, has serious allegations against it. The HPCSA allegedly passed racist and stereotypical remarks to qualified foreign trained doctors, solicited open bribery by telling graduates that people who pay get attended to. To the HPCSA also favor those who have political connection to jump the queue to write board exam and exam question on the subsequently leaked to those who pay or politically connected. Quite simple, this is unconstitutional. Bribery, racism, patronage, and political favor in any institution will not be tolerated. What is more demeaning in that the HPCSA is meant to have the highest possible stand of professionalism. In essence, the HPCSA is saying that it does not place the value of our constitution, professionalism, quality of service and standard as it is in the work. Minister, esihlale sikuzwa la yimibiko ethi noma sihambile saye emaklinikhi simama queue amade ekugcineni imithi singayitholi kodwa ngithokozile ukuthi uminister uyakwazi lokho uzokulungisa. Lapha ya eyibhedlela nasemaklinikhi kuyashoda khabazela. Awekho amanesi qualified, abekho abantu ingakho nje kukhona nale crisis esangakithi nje isibhedlela sibizwa ngesilaha. Ngoba imithi ayikho no nesi bayashoda. Kodwa umnyango ukhiphile ama-bursaries, ama-graduates ahleli emakhaya. Nabaqashiwe baqashwe ngecontract. Akeni nje babe permanent ukuze basebenze ngokuzimisela. Minister, ngiyafisa ukuthi uminister akuqikelele lokhu ukuthi umnyango lona usuhlala unamacala ngenxa yabantu abangekho committed emsebenzini. Kunale case nje yase RK Khanya Hospital eThekwini. Okunye okudalwa abantu abangekho committed emsebenzini. Ngakho siyacela ukuthi lo mnyango ukulandelele lokho. Okunye okungenziwa ukuthi uma umuntu esenze icase phela kangayi kwenye indawo ayomosha kwenye indawo akahamba uhlala ekhaya. Ngoba manje uma izobuya ayomosha kwenye indawo kade eshiye emoshile la ngeke sizwe sikulokhuze sikuvume lokho. Okunye minister uma abantu beretire lapha ngasemnyangweni onesi ayafreeza lawo mapost kwenziwa yini lokho? Abantu abagula abaresignile iyafreeze ipost kwenziwa yini lokho? Bese silindela kanjani ke quality yomsebenzi esibhedlela? Furthermore, the IFP calls on the department to place all graduates who hold bursaries with the department before the medium term budget reports. The department must work together with SAPS to ensure that the ambulance are fitted with the tracking device and emergency panic button.
Honourable Member, your time is now expired.
The IFP supported this budget so that these issues raised
Member,
can
your
be
time is
resolved
expired.
urgently.
The next speaker is the Honourable Van Staden. Order, Honourable Members.
Honourable Chair, Minister, Deputy Minister, members, guests. Ek rig graag hierdie boodskap aan almal in eerbied wat afgesterf het in hospitale die afgelope ruk onder vreemde omstandighede. Mag hulle in vrede rus. The Minister in the Presidency announced yesterday that the National Health Insurance Bill is on its way to Parliament after Cabinet's approval. The Honourable Minister also said, and I quote, "It will address the current health system that serves only 16% of South Africans' whilst excluding the overwhelming majority of South Africans." The FF Plus is of the opinion that South Africa has a public health care sector that has a footprint in even the smallest of settlements, but that is characterized by poor provision and a lack of expertise. On the other hand, the private healthcare sector maintains world-class standards, but is expensive and inaccessible. The biggest challenge in the public healthcare is not a lack of money, but a lack of expertise, mismanagement, and corruption have destroyed our healthcare institutions. The obsession with transformation means that even more expertise is forced out of a sector. Public healthcare infrastructure must first be upgraded before an NHI scheme can even be considered. The NHI can not be used for these upgrades. R2 miljard vir hierdie projek wat nie uitvoerbaar is nie. South Africa is not other countries. In short term, the NHI must be terminated at once. Voorsitter, die VF Plus het die afgelope tyd by verskeie medici verneem dat die NGV Suid-Afrika se gesondheidsorg in nog verdere afgrond gaan instuur. Die regering tree uiters onverantwoordelik op om te dink dat die NGV-instelling gebruik gaan word om hospitale en klinieke se infrastrukture op te bou en op te knap. Die regering moet besef dat die NGV nie die tekort van medici gaan omdraai en verander nie, maar tot gevolg gaan hê dat uiters ervare medici wat nog hier is, Suid-Afrika op groot skaal gaan verlaat. Dan, voorsitter, is alle drome aan skerwe en dit gaan Suid-Afrika in 'n groot krisis laat. Stop eerder korrupsie en begin om belastingbetalers se geld meer verantwoordelik aan te wend. 'n Gebrek aan voldoende verpleegers gaan die uitrol van die NGV onmoontlik maak. Volgens die vakbond Solidariteit het 8,535 minder verpleegkundiges sedert 2013 die arbeidsmag betree. Volgens die vakbond het gekwalifiseerde verpleegpersoneel vir sedert 2013 met 40% afgeneem. Hoekom? Want hulle is oorlaai met werkslading. Hulle werk te lang ure. Hulle werk in moeilike omstandighede by hulle werksplekke. Daar's 'n gebrek aan ondersteuning en toerusting in ons hospitale en klinieke en daar is 'n tekort aan geld in die klinieke. Voorsitter, maar kom ek vertel vandag vir u, wat is aan die gang op grondvlak in hospitale in Suid-Afrika? Sekuriteit by hierdie instellings is landwyd so swak dat verpleegsters, dokters, studente en pasiënte aangerand en selfs ook verkragt word, soos wat die afgelope tyd by 'n hospitaal in Bloemfontein gebeur het. By daardie selfde hospitaal, skaars 'n week later, het 'n persoon van die publiek opgedaag met 'n panga in sy hand. Dit kan nie langer toegelaat word nie. Ook by hospitale in ander provinsies word pasiënte, dokters, verpleegsters se lewens in gevaar gestel weens swak sekuriteit. Ons gesondheidsorg is in totale chaos in hierdie land. Nog drome is aan skerwe. Suid-Afrika se gesondheidstelsel is in 'n enorme krisis. Ons sit met gevalle waar pasiënte in hospitale afsterf onder vreemde omstandighede. 'n Pasiënt word vandag opgeneem omdat hy 'n been gebreek het, maar is dit te sê hy gaan lewendig daar uitkom nie. Dit is die stand van hospitale vandag in hierdie land. In die tydperk 2010 tot 2015 het die Gauteng Gesondheidsdepartement skikkingsbedrag betaal van nagenoeg R540 miljoen weens nalatigheid. Hierdie afgelope week het dit ook aan die lig gekom dat daardie einste provinsie se departement nog 'n verdere R1 miljard se regseise in die gesig staar. Ons het gesien wat aanleiding gegee het tot die ACDP tragedie, naamlik swak bestuur van die departement en wanadministrasie. Maar voorsitter, hierdie tragedie kon vir my gewees het as daar vroegtydig teen korrupte amptenare en voormalige LER op daardie tyd opgetree was, wat hiervoor verantwoordelik was. In 2010 reeds het die spesiale ondersoekeenheid 'n verslag hieroor uitgereik en oor 'n aandag aan die destydse president meneer Jacob Zuma, en daar is die verslag. Daar het die vereis van hom, ons het hom.
Honourable member, your time has expired. Thank you. The next speaker, order. The next speaker is the Honourable Deputy Minister of Health.
Thank you very much, Honorable Chairperson of the House, my colleague, the Minister, Honorable Dr. Mkhize, Ministers and Deputy Ministers present, MECs present, our Chairperson of the Portfolio Committee, Honorable Dr. Sibongiseni Dlomo, and members of the committee, honorable members of this House, various stakeholders represented here, distinguished guests, ladies and gentlemen. Chairperson, our debate on our budget vote today takes place just 6 days before we celebrate Mandela Day, which this year marks 101 years since our icon was born. This is also 25 years since President Mandela led our country into a peaceful transition from apartheid to freedom and democracy. Over and above leading us into the establishment of our democratic state based on the Constitution and establishing the key institutions that anchor the state, President Mandela led us in focusing on access to basic social services to the most vulnerable in society. In his first 100 days in office, he introduced, amongst others, the feeding schemes at primary schools, free health services for children under 6 years and pregnant women. In his lifetime, he also established the Nelson Mandela Children's Fund. And thanks to that initiative, we today have a long-lasting memorial for him, the Nelson Mandela Children's Hospital. Another impactful legacy of our icon is the Nelson Mandela Fidel Castro Medical Training Program, which Dr. Jomo spoke about earlier on, which is based on a cooperation agreement which he signed with President Castro in 1995. As of today, this program has contributed 731 South African trained doctors in Cuba, and also hundreds of doctors from Cuban nationals who are working in our health services, mostly in rural areas. Just last Friday, on the 5th of July, just 7 days ago, we witnessed the graduation of 87 young doctors conducted by the rector of the Medical University of Havana at Walter Sisulu University in Mthatha. The overwhelming majority of these graduates are serving in rural areas. One of the graduates of this program is Dr. Lindiwe Sidali. She is the first Black African female cardiothoracic surgeon operating at Inkosi Albert Lutuli Hospital in KZN. She comes from rural Eastern Cape in the Iduchwa area, and like many other families in the rural areas, they had to migrate together with their father, who's a mine worker, to the Northwest Province, an area called Wonderkop near Rustenburg, where she grew up and matriculated. If it wasn't for this program, Dr. Lindiwe Sidali would never have been a medical doctor, not to mention a cardiothoracic surgeon. We are currently in the process of bringing back 647 students to complete their integration. And they will be studying that program, the integration program, from the 20th of July up to the last to start will be on the 1st of August. The two groups of these students have already landed. The second group, which landed just yesterday at OR Tambo through an SAA chartered flight from Havana. And the last group will land on the 15th of July. The Cuban-trained doctors will add a lot of impetus into the improvement of our health human resource with a major focus in primary health care. They are going to be our building blocks on capacitating primary health care services in our districts. As we have stated many times, Honorable Chairperson, nurses are the bedrock on which our health services are built. The process of restructuring nursing education is at an advanced stage. All public nursing colleges have been restructured into one main nursing college per province, with sub-campuses in districts with a total of 76 of these sub-campuses in the whole country. 3 national curricula were finalized and used to develop province-specific curricula. The new 3-year diploma in nursing, as well as the 1-year advanced diploma in midwifery and selected postgraduate diplomas have been prioritized by all the nursing colleges. These programs will be offered in a phased approach, commencing with a 3-year basic nursing diploma at the beginning of next year in January 2020. Prioritization is aligned to the primary healthcare re-engineering agenda and also to other national priorities. The Department of Higher Education is in the process of developing regulations for the nursing colleges as higher education colleges in terms of the Higher Education Act. These regulations will specify that nursing colleges, while established under the Higher Education Act of 101 of 1997 as amended, will operate under the administrative oversight and management of the National Department of Health. In terms of a protocol to be signed by the 2 DGs, this will make possible for transitional mechanisms through which these colleges will be able to operate as of the beginning of next year, even when the regulations might not have been concluded. The 9 colleges, provincial colleges and campuses will commence with the diploma, as I've mentioned earlier. Further, other campuses will also start with other postgraduate diplomas, such as in critical care, in trauma, and other specialized courses, postgraduate diplomas starting in 2021. Honorable Chairperson, non-communicable diseases continue to outstrip infectious disease in our country, as illustrated by a report by Stats SA. A huge chunk of these deaths are due to cardiovascular diseases and strokes and diabetes. But cancer also has been a rising epidemic. These developments can be attributed to, amongst others, urbanization, commercial determinants of health, risk behavior such as tobacco use, and also harmful use of alcohol, but also unhealthy diets and lack of physical exercise. The challenge of NCDs is also not just local, but global. And as a result, in September last year, a high-level meeting of the UN General Assembly was convened by the Secretary General, and our own President Ramaphosa was one of those who attended, and we were also there as a ministry and department to give support to attend various parallel sessions and also civil society sessions. The Assembly passed a political declaration which, amongst others, expressed concern at the financial and human cost of NCDs, especially in developing countries, estimated at over $7 trillion over the next 15 years. The Assembly reaffirmed the primary role of governments in responding to the challenge by developing adequate national multi-sectoral responses. Our leaders committed to, amongst others, I quote, strengthen our commitment as heads of state and government to provide strategic leadership of prevention and control of NCDs by promoting greater policy coherence and coordination through whole of government and health-in policies as approaches and engaging stakeholders in appropriate, coordinated, comprehensive, and integrated, bold, whole of society action and response. So our leaders made very bold commitments. And also committed the acceleration of the World Health Organization Framework Convention on Tobacco Control without interference by the tobacco industry, also committed themselves to do everything to eliminate the marketing of alcohol amongst young people. Now, in this country, as a department and also with our stakeholders, we have taken some steps to make sure that this declaration can be a reality. Amongst others, a draft legislation on tobacco control was published in May last year to advocate a zero-tolerance policy, which will now prohibit indoor smoking in public places, including removal of smoking areas in restaurants and bars. Introduced regulation to restrict various categories of foodstuffs in terms of level of salt. Tax on sugar has already been implemented. The DTI is leading, together with our department, in enhancing visible health warning labels on alcohol beverages, and also reduce the age of where you can purchase alcohol from 18 years to 21. So these are some of the measures which we are taking. As I've mentioned, the cancer is also becoming an epidemic, not only in our country, but also all over the world. And we have taken some steps in this regard, launching a national cancer campaign in October last year in the KZN, the province of our chairperson, purchasing a number of linear accelerators to support our major hospitals, especially Charlotte Maxeke and Universitas in Bloemfontein. The HPV vaccine also has been rolled out as a form of prevention for cervical cancer. Also in the area of mental health, which is also part of our non-communicable disease epidemic, steps have been taken, amongst others, to secure more psychiatrists from the private sector to support the public health system, especially in the area of forensics, where there's a cloaking of the system due to the fact that in the courts, many lawyers, when they represent their clients, they put mental illness as part of the defense. And this is clogging our system, so we have to procure more psychiatrists to unlock the system. Chairperson, in the area of malaria, our country has prioritized elimination, not just reduction of malaria, by 2023. This means that we want to make sure that by this time we have zero new malaria cases. This is a very strong aspiration. We have made progress in terms of serious reduction, in terms of the incidence of malaria over the last 18 years by as much as 73%. The death rates from malaria have also come down by a rate of 74%. But we still have challenges. Amongst the challenges is the migration, mobility across country of people and mosquitoes. Because mosquitoes don't need passports. So they move from one country to another. So we have to work with our neighboring countries, and we are doing that with Mozambique, Zimbabwe, and Eswatini. But also we have to work with our provinces to make sure that we can do indoor residual spraying very effectively. There are 3 provinces in the country which are affected, which is Limpopo by province, Mpumalanga, and KZN. And we have worked well with our National Treasury to procure an amount of 90 million rand to support these provinces. And I hope our colleagues, I see the MEC of Limpopo and KZN are sitting together. I'm sure they will be planning how to do the indoor residual spraying together. Honorable Chairperson, just a few comments on some of our entities. We've got very effective entities within our department. The South African medical research continue to produce excellent scientific output through an NRF-rated scientists, including 2 of those NRF A-rated scientists in the leadership, and I see both of them here in the gallery. The chair of the SMR and MRC, and also the president and CEO is also here. Thank you very much. The MRC has, amongst others, just to highlight some of the achievement, discovered the new gene called CDH2, which predisposes young adults, especially athletes, to sudden cardiac arrest. And this has been done and identified with other global collaborators. Also undertaken, amongst others, a national TB prevalence survey with field workers already working in the Eastern Cape. Collaborated with Agriculture Research Council, very interesting, and a company called AfriPax, which deals in wellness products, to produce a substance which is one of the, identify a substance which is one of the active ingredients of rooibos tea. I hope you all take rooibos tea. This product will help you in managing cholesterol, amongst others, blood glucose, and also insulin resistance. So thanks to the MRC for this work. Also working on the center, establishing a study for antimicrobial resistance, because this is becoming another problem in the country and in the world. The MRC has also received 10 million rand to assist young South African scientists who are studying towards PhDs, because we want to increase our PhDs in clinical health research in the National Health Scholarship Program from the Public Health Enhancement Fund, which is our collaboration as a department with various private sector companies. This scholarship program has recently been renamed the Bongani Mayosi National Scholarship Program in honor of our late Professor Mayosi. Just to come to comment on the honorable member there from the FF Plus. One of our entities is the Council for Medical Schemes, which regulates medical schemes. And I'll not go into, but just a very relevant point which I want to bring to your attention. That the medical schemes industry in the last financial year paid out a total of 172 billion rand to beneficiaries, but also had in reserve 62 billion rand. Now, when you add these two together, it means the medical schemes were managing a budget in terms of paying claims and also reserves of 234 billion rand. Now, in the same financial year, the total allocated budgets for national health and also provinces was just 242 billion rand, a difference of 8 billion. Now, when this 234 billion rand was used to service only 15% of the population, 15.5%. Now, that difference of 8 billion accounts for funds which must service the rest of the 48 million South Africans, 85% of the population, and the difference between the two budgets is just 8 billion. To service 15% and to service 85. So while we must accept the fact that there's a lot, as the minister has indicated, that there are areas where we can be able to make savings, but the fact of the matter remains that this skewed, funding cannot be sustainable. It can't work. Nowhere in the world can this be sustainable. So that's why universal health coverage is very key, so that there can be equity in the ways the funds are utilized for health services.
Honourable Deputy Minister, your time is now expired.
Honourable Chair, I want to, the National Health Department is ready to implement the universal health coverage. We are ready for Tumamina and we are ready for
Honourable Deputy Minister, thank you for your input. The next speaker is the Honourable Soekers.
Honourable Chairperson, the ACDP notes yesterday's approval of the National Health Insurance Bill by Cabinet, which the President in his State of the Nation address said aims to reduce inequality and improve access to public health and private health facilities. We have one common enemy in this room, and that is indifference. Indifference to the plight of the poor and the vulnerable. Indifference is at the heart of a man who died outside a Western Cape hospital, provincial hospital, after waiting to be treated since the early hours of the morning. Indifference when a nurse cringes to perform basic observations on a patient because of the state of his appearance. Indifference when a young mother, inexperienced, scared, and overwhelmed after being up all night with a sick infant, is not addressed in a mother tongue, but made to feel foolish and unintelligent because a primary care nurse could not be bothered to take the time to listen or to call an interpreter. We have to ensure that we foster a caring and compassionate health sector, as set out in the White Paper on Health. The target set out by the Department of 50% satisfaction at primary healthcare facilities does not reflect that aim. It is sadly far from being realized. This said, we can learn from the example of health facilities, where I have experienced firsthand the commitment to best practice. The example should be lauded and emulated throughout our nation. Pockets of best practice is being displayed in some facilities. And a facility that I visited in Ravensmead, I met a young woman, wide-eyed, passionate about the health profession, a third-generation health professional, and she impressed me with her enthusiasm. We need to develop a retention strategy for our doctors, pharmacists, nurses, and we need to make sure that they are safe. We cannot afford to continue to bleed talented, passionate health professionals. Effective intersectoral collaboration is cited by researchers as key to address social determinants. Honorable Minister, we as the ACDP are calling on this department, together with the Ministries of Social Development and Human Settlements, to address with urgency the need for special housing. We have been urging the government for years to respond adequately to the plight of our most vulnerable people. This includes those suffering from mental illness, trauma, or abuse, and the elderly. Families are suffering under the weight and the trauma of caring for those who are mentally disturbed. Our current facilities are limited, and individuals who can be restored to health deteriorates even further due to a lack of treatment and care. That includes special needs housing. Mental illness has increased due to drug addiction and the destructive effects of drugs, such as tik and unga. We implore the minister to support this policy. It has been waiting for the last 20 years. Care cannot be siloed. Lastly, I wish to quote Florence Nightingale, who said, and I quote, "It may seem a strange principle to enunciate as the very first requirement in a hospital that it should do the sick no harm," close quote. Our hospitals should not be mortuaries, but places of healing. Thus, we appreciate the comments, and we appreciate what Dr. Dlomo has said here. South Africans are waiting for this house, for all of us, to work together to make their lives better. And I thank you.
Thank you, Honourable Member. The next speaker is the Honourable Ismail. This is the member's maiden speech.
Good day, and all protocols observed. Honorable House Chair, when I visited Mama Elsie last week from Imandleni Informal Settlement in Ekurhuleni, I found her ill and groaning with pain. I asked her if she had been getting any treatment. She told me that she had spent the entire day from before sunrise at a public healthcare facility. After waiting for more than 8 hours, she eventually got to see a doctor. Mama sat doubled in pain on uncomfortable benches with no food and no explanation. She said the nurses treated her with disdain. When she finally thought she would be helped, she was advised that the medication she needed was out of stock and she would have to come back later. The thought of trying to find taxi money out of a grant and another day in a long queue made her feel worse. She is just one victim of our collapsed health system. The shameful attitude of the state to the poor and vulnerable is, if you get sick, die quickly. Shocking, absolutely shocking. Healthcare is a constitutional right, but this department cannot even get the bare basics right. No Ubuntu and Batupele principles applied, unprofessional and uncaring attitude to patients. Patients have no sense of recourse as members on the board are political cadres. I then met Sis Jabu, pregnant and in labor. She rushed to a clinic for assistance. Because of poor facilities, she was told to go by ambulance to the hospital. So she called one. With her water broken and in the final throes of labor, no ambulance arrived. Baby Siyabonga was born outside the clinic. The ambulance arrived 3 hours later. Thankfully, there were no complications, otherwise we could have lost 2 lives. The EMS services in our health system are dysfunctional, yet the department increased the budget for emergency services by only 4.7% from 2018-19 to the current 2019-20 budget. Primary healthcare received the smallest budget allocation of 221.8 million rand, which is less than 1% of the department's budget. The bulk of the budgets are transferred to provinces, but this is exactly where these horror stories stem from. Minister, what are you going to do about it? One such example is the OR Tambo Hospital in Boksburg in Ekurhuleni. Now, we hear about plans and more plans, but no implementation on the ground for 25 years. Chairperson, the ANC government is putting the cart before the horse. They are wanting to drive through a problematic piece of legislation in the name of achieving universal healthcare. In reality, without the investment in primary healthcare, we will never improve the lives of our people. Billions have been spent on NHI, but what exactly can the department show for it? Visits to clinic and hospitals show very little. It is time to stop the talk and begin to deliver. Every day, lives are lost. Billions have been plowed into nothing at the cost of the poor and sick. We want universal healthcare for our people, but we do not want a piece of legislation that will destroy the health system as we know it. I thank you.
Thank you, Honourable Member. The next speaker is the Honourable Gala. Is it a maiden speech?
Honorable Chair, Minister and Deputy Minister of Health, Chairperson of the Portfolio Committee on Health, stakeholders of the Department of Health, ladies and gentlemen. The ANC rises in support of budget vote 16 on health. ANC policy has always been biased to the working class and has placed the marginalized and the poor at its center. The 52nd National Conference resolved that the health should be one of the 2 key priorities of government and planned this second phase of transition to be characterized by decisive action to effect economic transformation and democratic consolidation. Critical both to improve the quality of health life of all South Africans and to promote nation building and social cohesion. As such, government has maintained the balance between the number of policies interest based on priority and agency by ensuring that the National Department of Health receive one of the largest share in the budget allocation so that we can address all the challenges that we are faced as the Department of Health. Preventing and treating communicable and non-communicable disease. 1 round, 1 condom. No condom, no sex. So we must try to practice a healthy lifestyle as human beings. In combating HIV and AIDS remain a priority of the ANC-led government. The department is committed to the 1990 targets of the Joint United Nations Programme on HIV and AIDS. In this regard, the HIV and AIDS component will receive the bulk of grant allocation in order to continue the implementation of universal test and treat policy for ARV treatment. siyaqhuba mos bahlali baseMzantsi Afrika. Noko singathetha sitsho ukuthi abanamehlo bayabona, abanendlebe bayeva. I-ANC yenze umsebenzi omkhulu eluntwini laseMzantsi Afrika. Namhlanje abantu bayakhona ukufumana amachizi, ipilisi. Ufumana umntu ipilisi ibenye atsho aphile. So we want to lead a healthy society as a country. The ANC-led government has made substantial progress on its policy responses, the epidemic, and implement various interrelated intervention to interrelated intervention to mitigate and to stop the spread of HIV. Some of these interventions include, but not limited to: 1, National Strategic Plan for HIV, TB, and STI, 2017-2022, which serves as an overarching policy plan for South Africa. South African National Sex Workers HIV Plan, 2016-2019. The National Policy for the Prevention and Management of Learner Pregnancy. We know we still have a challenge at school of teenage pregnancy, which we must make sure that we address that, and as ANC government will do that. Comprehensive sexuality education, young women and girls program, sponsored by the Global Fund, Zazi, Know Yourself, Know Your Status. It's very important to go and test so that you can live a long life, because as ANC government, we can give you the ARV, as you know that is the medicine to make sure that we give our people. She Conquers program. In Persuade Out program 2, a long and healthy life for all South Africans, as seconded by the National Development Plan Vision 2030. South Africa is investing significantly on various interventions in the area of public health care. Some of the essential interventions to improve primary health care in South Africa include rollout of the male medical circumcision program, which is an aggressive rollout intended on reducing the number of men who are living with HIV. It is second that scaling up MMC should have significant health benefit, not for the men, but also for the women in South Africa. Fixed dose combination, ARV pill. The recent introduction of FDC ARV pill is the one that is the greatest success in the ANC-led government, has made the following outbreak of HIV and AIDS epidemic. FDC ARV pill is it's a once daily pill, as I've indicated ukuthi awusathathi lanto eninzi, uthatha nje ipilisi benye uphile. Dosage and makes it easier for those living with the virus. The pill is hassle-free as it improves and enhances and portability. Implementation of Mom Connect, which aims the strengthening health services and reduce maternal and child mortality. TB has been identified as the leading underlying cause of death in South Africa. I would like I would like to implore members of this August House to hint the call and be part of the global action known as Global TB Caucus, which was first established in October 2014.
Honourable Member, your time is now expired.
Malibongwe, we support the budget.
Thank you. The next speaker is the Honourable Sheikh Imam.
Thank you, Honorable House Chair, Minister, Deputy Minister, our colleagues in the House, and our colleagues in the gallery. Allow me, Minister, to congratulate you and your team on your appointments. In the SONA debate, the President spoke about a dream. And yes, indeed, 57 million people in South Africa have been dreaming, and they've been dreaming for a better, equal healthcare in South Africa. And despite 25 years into democracy, many of our people continue to be deprived of that right of equal healthcare in South Africa. Some are privileged, others are not. As if you are poor or underprivileged, your life has no value. Or if you have or you're privileged, then your life is valued more. And that's what the impression is. But also there seems to be a perception out here that private healthcare in South Africa is excellent service. And I beg to differ on that. Time and time again, I get complaints and concerns from the general public at private healthcare facilities and how poor the services are. So there is challenges both in the public sector and in the private sector. But one of the challenges we as the NFP identified is that in the appointments of MECs and CEOs and DGs and DGGs, particularly at provincial and local level, those at national level like ministers and things have very little or nothing to do with it. But it is the national department that has to account for it. And one ideal example is what I've heard from the former MEC from the Western Cape. She said how well they perform in the Western Cape and how well they're going to provide the services. But I can tell you that if she goes on a tour with me just for one day, I will show her what the conditions of healthcare is in the Western Cape. So it clearly shows that, Minister, if you don't have a role to play in appointing these MECs, this is what you get. They don't know what's happening in their own areas. But they're going to come out here and tell you how brilliant a job they're going to do. Now, let me tell you, let us be honest. The challenges that we face exist countrywide. There is no doubt about it. We have challenges countrywide. But those were some of the reasons why we face what we face. One of the concerns that we have is that the 15 to 24 age group, HIV new infections are still at about 1,200 per week, which is extremely high. And we believe that ARVs, while it's a temporary solution, is not the ultimate solution. The preventative measure should be rather considered more importantly, because we can't be continuously rolling out ARVs. We need to see what is going. I know I have a different idea of why there is HIV, where it came from to some of my other colleagues. That is my view. I personally believe man-made, that is why we are where we are today. I don't honestly believe that it is anything to do with the body. That is clearly my view. I think there needs to be greater oversight by the, not only by the committee, but the departments, because what we find time and time again, we've gone on oversight as the health committee. I mean, why is it that there needs to be a stock out and the only time you find out about it when it's in the media?
Honourable Member, your time has expired.
Anyway, the National Freedom Party fully supports this.
Thank you. The next speaker is the Honourable Hendricks.
Thank you, Honorable Chairman. My son Ismail is in the audience. He has mentored UCT students to develop apps for the bill and is doing his PhD on the NHI. And I hope the Minister will follow Minister Naledi and also do a doctorate degree. Honorable Minister, you promised to jump in to get the NHI bill approved. But you must take a giant leap to establish a state-owned pharmaceutical industry and factory to reduce costs. This will be the two most revolutionary steps the country will have taken since the dawn of our democracy. I agree with the fighters. The infrastructure must be fixed. Health facilities must be within walking distance of as many people in South Africa as possible. ICASA must give the health department their own 5G spectrum so your department can take the lead to show South Africa is ready for the fourth industrial revolution and be the first citizens of the cyber civilization. Jama-ah supports the budget. Jump and leap, Honourable Minister. Thank you to Cabinet for approving the bill. South Africa is shamed by being named as the most unequal country in the world. The NHA bill will be the silver bullet and the first step on the way to equality who many in this House fought for. Cabinet approved the NHA bill on the eve of Mandela Day. They've jumped the gun. Now it is up to you, Honourable Minister, to fire the silver bullet. As far as Jama-ah is concerned, the bill is now in an act. Expropriation of land without compensation of the fighters in the NHI bill voted for by the people must be the first steps to bring about equality in South Africa. Taxpayers' money to save lives is money well spent. So, Honourable Minister, get the bill passed no matter what the cost. We can recover from starving, but the poor cannot recover if they are dead. Equal universal health care must be the top priority in the land, but we need all political parties to work together, not to talk about equality, but implement it in the health care field. This is a unique opportunity to put politics aside and get to work, to do real work for the country.
Thank you, Honourable Member. The next speaker is the Honourable Wilson.
Thank you, Chair, and through you to the Minister. All we have heard today is empty rhetoric and your own backslapping about the few things you have got right. A few more bells and whistles and you can throw yourself a party. But over 200 billion has already been spent on NHI. But the state of health in South Africa is nothing to celebrate. Nothing. No one who relies on the public health system is celebrating. You know this, and we know that. The last week has highlighted just a few of the horrors patients in the public health services have had to endure. Elderly citizens tied to chairs. Elderly citizens found with maggots in their mouths. And a pregnant woman in labor being turned away because her womb was cleaning itself. None of them were in the Western Cape. KwaZulu-Natal has an ongoing oncology crisis. And in Limpopo, and by the way, thank you, Chairperson of the portfolio for the oncology crisis. And in Limpopo, the time between diagnosis of cancer and oncology treatment is 12 months. This is yet another death sentence like those of Life ACDP. But billions have been spent on NHI. Provinces who are allocated the bulk of the health budget play a crucial role in the delivery of primary health care. But astonishingly, the primary health budget has the smallest budget. There is a chronic shortage of critical medicines, equipment, consumables, and health professionals. Despite this, the provinces like Gauteng, for example, underspent their budget for critical equipment by 504 million. That is mind-blowing. The lawyers who represent the Gauteng Health Department in Medico claims have all withdrawn their services due to non-payment. Provinces and the National Department now face 80 billion rand in Medico malpractice claims. 80 billion. This is not budgeted for, just recorded as a contingent liability. If just half the claimants win their cases, provinces and the department have to find 40 billion out of their budgets. There goes your NHI, your infrastructure and building budget, your HR performance bonuses and critical equipment budgets. Already departmental and provincial and provinces accrued in the 2016 and 17 years 13.8 billion in accruals. and the situation is not improving. Simply put, Minister, you are robbing Peter to pay Paul. And as always, it will catch up with you. You start in the red before day one of the next financial year. We all know that the billions spent on NHI have done little or nothing to prepare for a universal healthcare system. In fact, in most instances, monies have been diverted from doctors, infrastructure, and equipment to pay accounts. The state of health has gone backwards since we started. Yesterday, Cabinet approved the disastrous NHI, and we're still waiting to see concrete plans and budgets. We're just talking. By the way, Sheikh Imam, Honourable Imam, the MEC of the Western Cape is not here, but the person behind hundreds of cancer deaths in KwaZulu-Natal is. Minister, we always talk about best practice. So go where there is best practice in South Africa, and even you cannot deny it. The DA-governed Western Cape is the leading province in terms of health service delivery. You cannot deny it, it is clear. We are yet to be in a position where we understand how your plans and what you have yet to present to us and what the total budget of this plan is. Are we going to not begin where we should, at grassroots level, and improving the basics in primary health care before we spend another 200 billion that has gone to waste and nothing to show for it? The Western Cape has done it, we've done it right, we've done it without the NHI.
Honourable
Please,
Member,
sir,
your
pay us a
time has
visit.
expired. The next speaker is the Honourable Munye.
House Chairperson, Honorable Frolik, Minister, Deputy Minister, respectively, honorable members, guests, and fellow people of South Africa as a whole, good morning. As members of Parliament of the Republic of South Africa, we are delighted and we welcome the Cabinet approval of the NHI bill, which will be tabled here in this Augusta's House as practical and urgent as possible. Now that we've been little bit attacked, I think it's important that we'll go out to be able to address those issues. Accordingly, we believe the department will develop a systematic improvement program within the national framework of annual performance plan. We have absolutely no doubt that the department needs to strengthen the systems, processes, and environment that help to sustain improvement and quality of service. His Excellency, President Xi Jinping of the People's Republic of China, I quote, the growing gap between the rich and the poor is both unfair and sustainable. He goes on to say, the development is meaningful only when it is inclusive and sustainable. I will talk to it later on the context of the NHI. I think what we have seen from the left, from the DA, it's important that we reflect on what Maxim Gorky has said. Truth doesn't heal the wounded soul. The DA is heavily wounded, and doesn't matter what progress the People's Glorious Movement, the ANC-led government, can do, there will continue to be forces opposed to progressive change and development towards national democratic society. It is within this context that the ideas or the ideologies, flawed right-wing ideology, that seeks to advance subjective factors rather than the objective reality. I know they've mastered now the left views of Lenin, open quote, a lie often told enough becomes the truth. They use the media, or the fourth estate, here referred as the media, unelected media, to confuse society and project the African National Congress and its members as corrupt. This is untruth. Where does this confusion arise from? Right-wing neoliberal agenda, which is subjective of reality. For the past 25 years, it remains a fact that the ANC-led government has been building clinics and hospitals. Going forward, we're concerned about building the quality of healthcare. To this end, we expect our Honorable Minister to come up with scientific mega or board infrastructure expansion proposal, how to build a new smart hospitals and clinics to accommodate NHI services. This will be aligned with the population growth, which will be fundamental necessity consistent with the 2030 vision. More South Africans are living longer. The average life expectancy increasing to 64 years in 2018, from low to 53 years in 2005. Progress in life expectancy reflects improvement in the quality and availability of healthcare. Our massive campaign to turn the tide against the HIV and AIDS and our effort to meet the basic needs like access to clean water, electricity, and adequate housing. More than 4.5 million people, or South Africans, living with HIV and AIDS, receiving antiretroviral treatment, up from 2.5 million in 2014, making the biggest antiretroviral treatment program in the world. We have made dramatic progress in prevention mother-to-child transmission of HIV. In 2004, over 70,000 babies born to HIV-positive mothers became infected. By 2018, this figure has plummeted up to 4,500, saving tens of thousands of newborn babies per year. New HIV infection have decreased, to our collective fight continues to the HIV-free generation. In 2009, there were 60,000 TB-related deaths, and by 2016, this had dropped to 29,000. Access to free primary health care has been expanded from pregnant women and children under 6 years under 6 years of age in 1994 to free primary health care for all today. Despite all this achievement, the struggle for good health care will continue. House Chairperson, the President and the Minister collectively demonstrated leadership on the NHI, which demonstrated political commitment to the bold 54th National Conference of the ANC. As the President Cyril Ramaphosa said, open quote, NHI is fundamentally about social justice. NHI will ensure that all our people, whether you are black or white, rich or poor, you will be able to access a comprehensive range of healthcare services. This one, we agree. Today we spend as a country, not as a government, over 8% of the gross domestic product on healthcare. This spend is far higher than many other countries of our economy size and more in line with advanced economy. According to many studies, this is more than enough to provide everyone to good health care. Going forward, despite high spending on as a country and despite progress made, many of health outcomes remain stubbornly disappointing. We know that despite these youth healthcare resources, the country has a good healthcare in front of everyone. There are many who do not get healthcare when they need. We must respond to this important question as to why. As the ANC-led government, the root causes can be found in two-tiered health system we inherited from the apartheid era, which reproduce the systematic inequalities in access and good quality care. It is a system made of huge medical aid-funded and highly resourced private healthcare, herein referred as the first tier, designed primarily rich elite and public underfunded public health care for the poor majority of our people, as referred in as a second tier. Despite 25 years of the major intervention to transform our health system and many achievements recorded, two-tiered unequal system remains stubbornly high. We in the ANC have declared that the answer to our two-tiered healthcare system is not an incremental market forces-driven solution, as suggested by the DA in the left, to problems of our health coverage and healthcare, quality healthcare. All DAs what seeks to do is to main the central of a private health insurance in our national health system, hereby reproducing inequality, which is not sustainable in healthcare and will be rejected. This will be rejected by the 6th Parliament. what needs to be done to change the two-tiered health system itself. Only the ANC have a solution to all the people, to all our people. To this end, we have proposed the publicly financed national health insurance program that will fully cover care for all South Africans. NHI, therefore, is a universal, comprehensive, affordable, will provide free health care to the point of use. We will eliminate the need to two-tiered healthcare system dominated by the private health insurance. We will putting forward progressive single unified national healthcare system. As the NHI white paper notes, open quote, NHI represents substantial policy shift that will necessitate massive reorganization of the current healthcare system to address the structural changes that exist in both the public and private sectors. It reflects the kind of society we wish to live in, one based on the values of justice, fairness, social solidarity. Implementation of the NHI is consistent with the global vision that healthcare should be a social investment. The white paper also knows that, open quote, the implementation of the NHI is underpinned by the Vision 2030 of the National Development Plan, which envisages that the 2030 everyone must have access to equal standard of care, regardless of their income. And that common fund should be enabled to enable equitable access to healthcare, regardless of what people can afford or how frequently they need to use the service. As the ANC, we have a clear electoral mandate to ensure that we do achieve this by 2025, 2026. This is our target year, in which the NHI fund will be fully functional, with access to all revenue collections, covering majority and also entire populations, with purchasing capacity to pay accredited healthcare providers who meet quality standard. Therefore, one of the immediate priorities of this sixth parliament is to ensure the tabling of the NHI bill. That will set a foundation to roll out of NHI implementation. House Chair, it is part and parcel of the NHI implementation to ensure that we strengthen provision of healthcare services, particularly in the private sector, in public sector, not private sector, with strong emphasis on primary healthcare. This could entail the building of the primary healthcare network that includes school healthcare services and radical improvement in the performance and quality service of primary health facilities. NHI implementation will require adequate planning for that production and distribution of human resources for health, including absorption of the tens and thousands of the healthcare workers who the minister talked about earlier, who are paid above national minimum wage. We also need to strengthen nursing colleges and medical school. This the deputy minister talked about, while building the successful partnership and medical training program with Fidel Castro, Dr. Nelson Mandela program, a country renowned for its own best, Cuba, a country renowned for its best healthcare system in the world. House Chair, the cost of medicine and drugs has been a major concern of the ANC government. We played an important role in reducing the cost of the same essential drugs and continue to do so. However, as part of our efforts, we need to build domestic capacity to produce our own medicine, biosimilars, and medical equipment through creations of the state-owned pharmaceutical enterprise. This is consistent with our own both 53rd and 54th National Conference. Within the Department of Health, we need to have capacity to meet the needs of our national health system. The intervention must be understood, House Chair, that the contest to drive industrialization through localization and leveraging on the economy of healthcare through its huge public procurement spend. Health is a global business, international relation, political economy, and related international trade. South Africa must reject, and I think it's important, House Chair, that we indicate that Professor Wood from Oxford University analyzes and has said that there's a global economic shift in the globe, that the shift is in the developing nations. So therefore, the developing nation led by China have the capacity to be able to acquire strategic assets which can benefit all the developing nations as a whole. So it is important that we must reject unilateralism of Trump and remain solid and shakeable on the multilateral systems. We must make sure that World Health Organization, WHO, must be able to spend most of its capacity and work within the developing nations. The country is an importer, not exporter, that is linked to hard currency such as dollar and euro. I mean of these ARV drugs and other medicine. It is the currency volatility which will continue to affect the pricing and import of drugs because they shipped in large volume. The additional cost of logistic and warehousing will definitely impact on the higher cost of procurement or on medicine which will be banned by the patients. It is within this context that the 53rd and 4th National Conference resolution, I repeat again, resolve on the establishment of the pharmaceutical state-owned company. We can no longer postpone this issue, Minister. The healthcare sector is not blind. The healthcare sector is not blind to digital revolution, especially on artificial intelligence, could unleash huge potential in digital healthcare technologies, ensuring enhanced access for good quality care, especially our people in rural and remote areas and part of our country. We therefore are looking forward to contribution of the Department of Healthcare to invest in digital healthcare services, including smart health facility within the context of the NHI implementation. Consistent with the Department of Health annual performance plan on the strategic approach on National Strategic Framework 2014-2019, open quote, the era of digitization technology will be extensively used to leapfrog health system to implement NHI policy. In taking forward this decision, our portfolio committee also resolved that the ministry need to have an interministerial engagement with Department of Communication and Digitization to secure a telecommunications spectrum dedicated for e-governance with a key focus on healthcare technology to reduce the cost of services. We are very clear that the spectrum will also be utilized to make sure that artificial intelligence or technology will be able to provide surveillance and face recognition technology, scan platform that will be able to ensure that safe and secure hospitals and clinics, and combat thefts of medical drugs such as ARVs. The health workers.
Honourable Member, your time is now expired.
We support the budget.
Thank you. The next speaker is the Honourable Minister of Health, who will respond to the debate. Honourable Minister.
Thank you, House Chairperson, and thank you to all the members for all the comments and the suggestions and the input. I just want to finish off by also indicating that the full package of services that we'll be looking at is contained in the speech, so it will be sent through. But I want to thank all the excuse me. I want to thank all the stakeholders who are here. In particular, I want to congratulate the Medical Research Council on the 50th anniversary of excellence. I also believe that, which they are celebrating this year, it's important for us to celebrate the hard work, the excellence, the professionalism of all the public servants in our system who are dedicating their lives in making sure that we get the best services. So I want to salute all those public servants who work in our system. In particular, I also congratulate, as the Deputy Minister, Dr. Sidali, Lindiwe Sidali, who is the first cardiothoracic surgeon, and Professor Mashudu Sifularo, again, on being the first to do world transplant middle ear bone on 3D technology. And in thanking everyone, I'd like to also thank President for his leadership, the Deputy President for his SANAC leadership, colleague ministers, and the department, Deputy Minister, for all the work that they've done to help us with this speech. It's time now for us to implement. It's time for Kauleza, and therefore we're ready to go to do battle. The NHI bill is out from Cabinet. It will be processed by this House, and we'll continue to support. We're doing briefing to the media just to give them a sense, because there's a lot of interest. The issues that they've raised amongst them is that we agree that there's a need for strong consequence management. I just want to say to Honorable Jomo, I agree with you, Honorable Member, Most countries that have done NHI, they've done so when they were, their economy was lowest. Japan did the same, UK did the same, we're there with them. They were actually explaining, you can't be more wealthy to implement NHI, just go ahead. I also think that the Honorable Kwahube, I'm very sorry, Honorable Member, I think you decided to distort the issue. In the first instance, I did say that the pilot report is not out, but I said specifically, it does not matter what the weakness is that it will show. We will have to solve them anyway. So that is the attitude. We will solve whatever the attitude can. Doesn't matter what they are, we will solve them. Now I see that the DA spin doctors were busy playing around. I think you're also trying to polish your marbles. The issues of the DA, already you now are no longer opposed to removal of tax benefits for medical aid. How? That's new, that's interesting. Then the regulation of medical aid, for years you've been opposing this. Welcome to the club now. Or we should say, molo fish upumeni netinin. The Honorable Tenjegwayo, well, you support the NHI. Somewhere along the line, you don't like the budget. Let's work with the support. I don't mind the rest. The Honorable Shengwa, your issues, the president of the HPACSA is here. This is a body of professionals with high integrity. So just bring us the report. All the things you report are not about the HPSA. If there are individuals who are misbehaving, we will investigate them and deal with them. So the other issues that have been raised here, don't try and dissociate yourself from the health system and its weaknesses. I looked at the TB figures. Western Cape is just as bad as the whole of South Africa. So we take responsibility for the weakness in your system. We take responsibility. If you have delusions of dissociation, that's your problem. We are going to work on this system and fix it. It doesn't matter which side. So the other member was saying that we spent 200 billion on NHI. Sorry, get your figures right, that's wrong. The other issue of 80 billion on medical legal, those are projections, we haven't spent that money. So, but some, if you are fixed to criticizing the ANC, do it on facts so that we can deal with the issues properly. Now, so we are going forward to fix the health system. Emakaya siyafisa bazi ukuthi sifisa ukuba isimo sezempilo kunciphe imigqa emide ezibhedlela kusheshe kutholakala imithi kutholakala odokotela abahlengikazi abaningi nonompilo babe khona iyona ke le NHI sifuna bayenzeke konke lokho okunye ukwenziwa kwezibhedlela zilungiswe konke sizokusebenza sokwenza kanye kanye kodwa akuzuthi ngoba izinto zixakile bese sithi konakele konke asukwenza lutho thina ke sikhethela ukuthi sisebenze nabantu silungise isimo sempilo sibe yilento abayifisayo ngaleyo ndlela ke sithi ke phambili ne-NHI siyaqhubeka. Thank you.
Thank you, Honourable Minister. Honourable members, that concludes the debate. I just have the following announcement to make. The Honourable Minister is inviting Honourable members and guests to a cocktail reception at the Good Hope restaurant immediately after this sitting. This mini plenary will now rise. Thank you.